I'm very, very proud of the Joint Hospital's willingness to embrace this problem and work towards a solution. Joint Hospitals being St. Joseph's Healthcare and London Health Sciences Centre. So one of my administrative roles is to be the vice chair of the Joint Medical Advisory Committee for the hospitals. And in that position, I think it was back in September, I was asked to create and lead up what we call the Opioid Stewardship Council. So the OSC, or Opioid Stewardship Council, is comprised of a large number of people who are stakeholders in managing and improving upon the opioid crisis facing London and the surrounding region. So, for example, we have various physicians, anesthesiology, emerge physicians, pharmacists from both sites, nursing staff who are stakeholders from both sites. We have trainees on the committee. We have a patient care advocate on the committee, and there's a few others. And everybody here has a role to play. Even if they're not a prescriber, they see the consequences of the prescription. They see the amounts that are written, and they have to counsel patients when, where, and how to fill it. Trainees have a huge role to play because they are frequently in the teaching hospitals the ones who are actually prescribing. The nursing staff are very heavily involved in pain management as they counsel patients post-op or after an emerge visit what their pain might be like. And so this wonderful group of dedicated individuals came together and has really brainstormed and worked within the hospital infrastructure to find ways to improve this crisis. That's where the idea of changing our computerized order entry system came from. We're trying to develop tamper-proof prescriptions so that people cannot write their own words or retype or Photoshop, copy, print on the existing prescribing papers, a different number, for example. The group has done a great job developing educational pamphlets that will be printed out with prescriptions that will go to patients along with their narcotic prescriptions to say you needed a narcotic for this reason, and it's okay to take it, but beware of A, B, C, and D of the issues that could arise. So we're improving patient education from this as well. We have educational initiatives that are being developed through the hospitals to educate both prescribers and non-prescribers about the extent of the crisis and what we're doing to abrogate the response. So the OSC group has really been, I think, instrumental to the sport. I'm very privileged to work with such a group of people because this is much more than a one-person, one decision sort of show. And ultimately, there is a prescriber who writes the prescription. But in my mind, it's almost kind of like a funnel, right? So we have the team who is involved in caring for the patient in acute pain, working through that process. There's the prescriber who writes the prescription, and there's all the downstream effects after the prescription is filled as to what happens to those tablets that are out there. The team up here is where the solution is going to be starting, right? Because we have the intake of the patient who's coming in with acute pain, whether it be, again, in the emerge, in the operating room. They've had an event happen that causes acute pain. Physicians, nurses, allied professionals, trainees are all involved in helping patients through this moment of crisis in their lives, one part of which is the pain medication prescription. So when we start with educating patients, empathizing with them, sympathizing with them, and offering them alternatives to pain control beyond here's more Tylenol number 3s, that's where the solution is going to start.